Thank you everyone for joining. Good evening. Thank you for joining us for tonight's webinar, Take the Next Step with EQIP. We're pleased to be joined by MedCai EQIP team, Olivia Simon, and she'll provide an overview of the episode quality improvement program, including how the program works, participation requirements, performance evaluation, and what practices need to know to get started. We'll also hear from Dr. Mark Gruner, who helped develop the musculoskeletal episode for EQIP. Dr. Gruner is a Mayo Clinic trained interventional sports physiatrist specializing in musculoskeletal ultrasound and sports medicine. He will discuss his own experience with EQIP and will share why practices should consider it. Thank you all for being here. We appreciate your interest in learning more about this program. And now I'll turn it over to you, Olivia.
Great. Thank you so much for having us tonight. And thank you everyone for taking the time to learn more about the EQIP opportunity. I actually want to start by passing it over to Dr. Gruner to kick us off today. We just heard, we're going to go through a full overview, but I want to start with why you should even consider learning more about EQIP. So Dr. Gruner, to you.
Yeah, so thanks, Olivia. Olivia and I have talked to a lot of practices across the state of Maryland. And for anyone who doesn't know me, I'm a practicing physician, Ortho Bethesda, grew up in the Montgomery County, Maryland area, and after fellowship at Mayo Clinic, came back and have practiced here most of my life. I worked at CMS on innovative value-based care models and had the opportunity to work with MedCai and HSCRC designing one episode. And then I've been a consultant for PACES, helping them redesign a lot of their musculoskeletal episodes. So, my hope today is just to explain why you should do this. This is a no-brainer for a lot of organizations. So I'll start off with, right now, if you take Medicare and you're in a Medicare fee-for-service system, you have to do two quality reporting options. Option one is you do MIPS, which is called the Merit Incentive Payment System, and it's a +9 or -9% on all of your Medicare money by uh, by by participating with Medicare. And independent practices, unfortunately, because they don't have the resources, have really suffered significantly for their to get a bonus payment, and sometimes they're seeing penalties. So instead of reporting for MIPS, there's an option in the state of Maryland that I think is really exciting called EQIP. So if you're an independent doctor, if you're a hospital, if you're a provider group, you have an option instead of getting a penalty or possibly a small bonus, you have the ability to get a upgrade to your Medicare fee-for-service schedule, which is called an APM participant status. And by participating in this model, and you get you're exempt from MIPS, and you get an APM bonus factor. That bonus factor is usually significant, and it's more significant than what the MIPS bonus is. So for people who don't like bureaucracy and reporting, this is an easy way to participate. Second, by participating in EQIP, it's made up of over 100 episodes. And if you show savings, and we'll go over this, and you earn savings, you can earn a significant amount of money. And I work at Ortho Bethesda. We've seen millions of dollars in savings from this program. The third thing, which I think is really exciting, is it's claims-based reporting. So there's no extra work that you have to do at the practice. The quality measures, the reconciliation on cost is all done on the back end by the state of Maryland through the HSCRC. Next slide. So so enrollment is opening now. So you have from July 1st to the end of August to decide if you want to participate. And there's a process that Olivia will discuss. But this is going to be our PY year. I just want to make sure I say this right, Olivia, 5 or 6?
This is going to be performance year 6, 2027.
Six. So this will be performance year 6. We've had 3 years of track records, and Doctors' practices in the state of Maryland have saved over $62 million in Medicare savings, with bonus payments going to the doctors totaling about $29 million. So, um, this has shown a really good ability to lower costs and to give an opportunity for physicians to earn incentive payments outside of billing fee for service. Next slide. So, what is the episode quality improvement program? Well, at CMS they love acronyms, but EQIP is essentially a way for a there's over 100 episodes, and it's a way for us to show quality and cost savings. And the way we do this is there's an episode, and an episode has a beginning and an end. And if you show savings between the beginning and the end, whether that's a procedure like a knee replacement, which is a 90-day episode, or managing knee arthritis, which is a year-long episode, and you show savings from a time in the past, which is called the benchmark year, to the performance year, you earn savings on that money. Next slide. So, what's really important to know is that um, how does EQIP work? So, it's very simple. It's not based off your TIN or your tax status or your PCOS or Medicare status. It's you sign an individual contract in December after you decide that you want to participate, and that's with the HSCRC to participate in the EQUIP group. And you can decide whatever entity that you want to be called. That's called an EQUIP entity. So you could have one or many practitioners within your group or within several groups that participate in one EQUIP entity. And I think there's a really important opportunity to learn more about this. If you want to learn more, you can reach out to Olivia to understand what's the best opportunity for me to show the most value, to make it really easy. Do I team up with other doctors? And you'll do that by being part of an EQUIP entity. The second part is understanding the clinical episode. So within an entity, there are many episodes. So one episode is the knee replacement bundle. Another episode might be low back pain or sinusitis. And so an episode is broken into two different things. One, it has a distinct trigger event. So what that means is you go and look at a hospital stay or a CPT code of like an office visit or a CPT code of the surgery being performed for a knee replacement in the ambulatory surgical center. And then it looks back, the software, there's a piece of software that's used, looks back at a previous date and then looks forward to 90 days forward. And they look at that episode and they figure out what the average cost of that episode is over a 90-day period for a procedure or over a year duration for managing a chronic condition. And they come up with a uh, benchmark cost. So, for example, benchmark cost for managing osteoarthritis for the year might be $10,000. And that episode would be compared to a previous year, which is 2019. And if you lower the episode cost of $10,000 to $9,000 when you're in the performance year, which would be 2027, you earn $1,000 extra for that patient and managing that patient in a conservative manner. Next slide. So each year, there's been more and more episodes. There are now over 140 episodes. Some of them are procedural based episodes. So someone getting a knee replacement, someone having a cardiac stent. Some of them are condition based episodes. And we have them for all different types of procedures and conditions that exist in medicine. Next slide. So this is just another example of a condition-based episode. A condition-based episode can be a primary care doctor, it could be a specialist. And what happens is there's an office visit, usually a 213 or 214 or 99203, and one of these ICD-10 codes. And the software, what it does is it recognizes the office visit with one of these codes. This is not extra work that you need to do. And then there's a trigger event. And if you see that patient and manage that patient over uh, the most amount of times over the course of that year, you are attributed that patient for managing their osteoarthritis condition. And so if you are making sure they're not getting MRIs, making sure they're not getting unnecessary surgeries, really manage them in a conservative, value-based care fashion, and you beat that benchmark over your performance period, you earn savings for managing that patient. Next slide. This is an example of a procedural-based episode. So before we talked about condition-based episodes, which tend to be a year in length. A procedure-based episode's 90 days. So that's from the time they get surgery to 90 days after the surgery. And what's unique about these is there's lots of good opportunities to lower costs from taking patients from the hospital to an ambulatory surgical center, making sure that they don't have infections or emergency admissions to the hospital during those 90 days. And if you do that, you can see a lot of savings in the procedural based episodes. Next slide.
And I think I'm going to take it over from here, Dr. Grinner. Thank you so much for kicking that off for us. And if anyone has any questions, I just want to add that you can please feel free to raise your hand, come off mute, type in the chat. But now we're going to talk a little bit about the episode cost. So Dr. Gruner already mentioned how your episode costs will be compared to that benchmark or that baseline. And we'll touch on that a little bit more on the next slide. But I just really want to emphasize here, all of the episodes and then any of the related costs that Dr. Gruner mentioned are going to be identified based on your Medicare fee-for-service claims. So again, no additional reporting required on your end as a participant to track any of the episode triggers or costs associated with them. However, it is important to know what types of costs this program is looking at. So EQIP will be looking at the Medicare Part A and B claim payments for any services that are considered clinically relevant to the episode and occur within the episode's time frame. Now, it is important to note that this is regardless of who provides them. So if you're the attributed practitioner treating a patient for a particular episode, and that patient then is admitted to the ER for something relevant to the episode, those costs at the ER may actually be included in your overall episode costs if they, again, are considered relevant and occur within the episode's time frame. Here on the screen, you can see some examples of episode costs that would likely be included: inpatient stays, outpatient visits, imaging, labs. Part D drugs are excluded for this program. Other physician services and durable medical equipment if applicable. So this is just a little bit, again, of an overview of the types of costs that this program would be looking at. Now I want to talk about that benchmark and how you're really evaluated in this program. So your current performance or costs, so let's say your 2027 episode costs, will be compared to a target price or a goal price that is set for your entity. Again, the entity is just the way in which you participate. It can be one or more practitioners who you sign up with. Each entity is going to receive a unique target price for each episode that it enrolls in. So if you participate in diabetes, low back pain, and osteoarthritis, you would get 3 unique target prices or goal prices for those entities. This is a pretty neat component of the EQIP program. There's not one target that is assigned to all participants. It's really based on your entity's historical episode cost. So when I say that, the program basically goes back to the baseline year, which is currently 2019, and looks at the entity's average episode cost during that year. So for example, let's say you're enrolling in the diabetes episode. Whatever the entity's average episode cost for diabetes in 2019 is, becomes the target price or the goal price that you are trying to be less than in 2027 to generate savings. So if your performance year costs are less than your target price, then you have generated savings or you have achieved your cost target for the program. Now we're going to shift gears a little bit and talk about quality. So the majority of this presentation so far has been around the episodes and their costs. And that is, again, the number one priority of EQIP. You need to generate savings in order to be eligible to earn an incentive payment. However, your incentive payment may be modified based on your ability to perform some specific quality measures that this program includes. So for each episode that is attributed to your entity, there are 4 measures that would be included. So the first is advanced care plan, then we have medication reconciliation, then we have BMI, and then unplanned hospital readmissions is a new one, and it's only applicable in certain scenarios. The 3 that I want to focus on are the ones I listed first. So we have, again, advanced care plan, MedRec, and BMI. The neat thing about these measures is they're also claims-based, just like the episodes, triggers, and costs. So what that means is to get credit for these quality measures, they must be submitted through claims using the CPT2 or G codes at least once by any practitioner who sees that patient within 1 year prior to the end of the episode's period. So on the next slide, I have a little bit of an overview of each of the quality measures, but the big thing I want to highlight here is start at the bottom. So here we have, again, those submission codes, the G codes or the CPT2 codes that would need to be included within the claims in order to get credit for the quality measures. This slide deck will be shared with you all. And I do want to mention on the previous slide, we've linked the CMS documentation to all of the measures here. So if you want to read more about them, learn, what's included or why they're even selected, you can absolutely do so. But the biggest takeaway here is its quality reporting is also claims-based. Okay, so now we're going to get into the fun part, which is how is your incentive payment determined? How is your overall performance evaluated? So we already touched on the first piece of this, which is your total performance, your episode cost will be compared to your target price across all the episodes that you participate in. And if your episode costs during that year are less than your target across all your episodes, you are eligible for a shared savings award. Now, there's a few other things in place that you must also meet to be able to move forward in this payment methodology. The first is that you've achieved the minimum threshold to get savings, or get a shared savings payment. The program basically just says you need to achieve at least 3% of your entity's aggregate target price for them to say, yes, your savings are considered statistically significant. So that's one check. The second is if you participate in multiple years and you generate dis savings in any years, meaning your performance year costs exceed your target price, you would have to first offset those cumulative dis savings from previous years before we move forward with this methodology. As a first year participant, you would not need to worry about this. But again, I just want to be upfront that this does exist and this must occur before you can move forward with your payment. So that's step number 1. The second piece of this is the shared savings split with Medicare. So this is a shared savings program, which means the entity would get to keep a percentage of any savings generated, and Medicare would retain the other percent. So your entity will be ranked in one of 3 tiers based on efficiency compared to their peers in the state at the state level. So tier 1, getting 50% of savings, Medicare retaining the other 50%. And then tier 3, the entity is getting 80% of savings, Medicare retaining 20%. This tier would be shared with your entity by the program administration. And then lastly, this is where those quality measures come into play. So whatever your shared savings amount here would be reduced by 5% pending your quality assessment. So basically, there are specific thresholds for each quality measure. And based on how well you performed the quality measures, you would get to earn up to that full 5% back. So I'm going to give you a silly, simple example just to help visualize. but let's say your shared savings payment was $100. That's what your entity got. It will be much more than that. But let's say that it's $100. 5% would be withheld, so they would take $5 away. And then if you got, met all of the thresholds for the quality measures, they would give you the full $5 back and you would end with $100. If you fell somewhere in the middle, maybe they'd only give you 3% back and you would end with $97. So it's only up to a 5% reduction. And again, depending on how well you perform those measures. Whatever the final amount is here will be paid in full approximately 9 to 12 months after the end of the performance year directly to the payment recipient that is designated during the application process. So when you sign up, you basically would indicate where any shared savings would be sent. Now, I do think it's important to quickly talk about, well, what happens if you don't meet your savings target or your quality measure scores? The great thing about this program is there is no downside risk at the practitioner level. EQIP entities practitioners are never going to be expected to repay CMS if they don't meet the measures. However, there are some policies in place to ensure that participants try to improve in both their costs and quality over time. So the first is the savings policy. The first part of this policy I touched on the last slide. Before you can get your incentive payment, you must offset cumulative DIS savings from prior years. But additionally, if you generate DIS savings in 2 consecutive years and are in tier 1 or 2 of that tiered shared savings split, you would have to sit out of the program for 1 year before you could re-enroll. With quality performance, if your quality measures for any of the quality measures fall below the 20th percentile benchmark threshold for 2 consecutive years, same thing, you'd have to sit out for 1 year before you could re-enroll. So there's really no risk at the practitioner level at all to be in this program, which is why Dr. Gruner in the beginning was really encouraging you to, sign up for this program, at least for the first year and see how it goes. You're never going to owe money out of your own pocket if things, don't look good for either cost or quality. Okay, so now I want to take a moment to talk about who's eligible to participate and then go over some next steps for enrollment. So the criteria to apply or be in this program is that you must be a practitioner, CMS approved practitioner in the state of Maryland. You must be enrolled in the Medicare Provider Enrollment Chain and Ownership System, or PECOS. You must use a certified electronic health record technology. You must work with CRISP, which is Maryland's Health Information Exchange. If you don't currently utilize CRISP, there is the opportunity to get set up with CRISP, so that's no worries. And then lastly, you must meet the EQIP volume thresholds in the baseline year. So again, we're looking at calendar year 2019. There are specific thresholds you must meet to enroll in particular episodes. I'll briefly touch on them now, but just know you don't have to calculate these on your own or anything like that. The program administration can help you determine which episodes you're eligible for. But just so you can start to think about it, what the program says is you must have at least 11 episodes in the baseline year per episode you want to select. So for example, if you would like to select diabetes, in 2019, your entity must be attributed at least 11 diabetes. If your entity was only attributed 9 diabetes episodes in 2019, unfortunately, you could not select it. Additionally, your entity must have a total of 50 episodes in the baseline year across all the episodes you select. So for example, if you want to participate in diabetes only, you would need 50 or more. If you want to participate in diabetes and low back pain, you could have 25 in one, 25 in the other, and meet your 50 that way. Those are just some examples. Again, don't stress about these numbers. The program admin can help you figure out if you meet these thresholds. Last but not least, at least 75% of the NPIs that make up the entity must contribute to volume in the baseline year. This threshold is smaller for entities that have 10 or less practitioners. The threshold for those entities is 50% of NPIs with entities 10 or less practitioners must contribute to volume. So hopefully this can get you just to start thinking about if you meet the volume, but again, we can help you determine that. So now I want to just talk a little bit about next steps. So the enrollment period for 2027 actually opens on Monday. So the enrollment period was shifted a little bit earlier this year. So it runs from June 29th and then it will close on Friday, August 21st. During this time frame is when you would need to complete the official EQIP application. So it must be submitted by August 21st. With that being said, if you are a brand new participant to EQIP, you must complete the pre-enrollment form to get access to the CRIS portal where the application lives. So this form is linked here. We'll send it out after this meeting, but it must be completed by August 7th. It's not the official application. It does not lock you in. I encourage everyone to fill it out today or soon, even if you're not sure if you want to move forward. It just gets the process started if you would like to. You also can then submit that baseline volume report to determine your opportunity to participate. So this is what I was mentioning on the last slide. If you fill out the baseline volume report, you will see what episodes you have volume for. This is optional, but highly encouraged so you can make an informed decision about your participation. And then I've also included the CRISP team email here. The CRISP team really serves as the true program admin, facilitating the enrollment processes. So if you ever have any questions, this is another resource that you can reach out to. Before questions, I just want to end with a few additional resources. So there's some things you can do to plan for CMS vetting, which takes place following enrollment. So after you sign up, all of the MPIs that were included in the application will be run, and CMS, will make sure you're eligible to move forward and whatnot. So there's some resources here. You can take advantage of them and start planning for your CMS vetting. We also helped MedCai helped Chris develop the EQIP curriculum, which is a series of short 5-minute or less learning modules that break down different elements of the EQIP program. If you're like, this is a lot and I really want to learn more, I encourage you to go explore the curriculum. And then we also have the subgroup meeting that meets on the third Friday of every other month. This is hosted by MedCai. Anyone can join. All EQIP stakeholders are welcome, even if, again, you're not really sure. Our next meeting will be in July, and all program updates, announcements, conversations happen there. So please feel free to join if you're interested. I put the MedCai EQIP email in the chat earlier during this meeting, but you can reach out to either me or the MedCai team at medcaiequip@medcai.org. We can set up an individual meeting if you want to talk more about how this program specifically would work for your individual practice. All right. With that being said, I don't think I saw any questions in the chat. Dr. Gruner, do you want to add anything?
No, Olivia, you did a wonderful job. I just want to thank Montgomery County Medical Society for giving us the opportunity to talk about this. I really think this is a really important when there's things that are easy wins for practitioners, this is an easy win for you guys, and a way to not get burdened down with bureaucracy and have to do MIPS payments, be able to get an APM payment, and be able to really see a bonus payment. Like I said, at Ortho Bethesda, we've seen millions of dollars in savings, which has been great. And we've done a lot of things that I think are great. We've taken surgeries from the hospital to the ASC. We've really made sure that patients are getting appropriate physical therapy. We've reduced emergency admissions. I'm sorry, I think my son is crying in the background a little bit right now, but it's the witching hour at the Gruner household right now. But yeah, I really think this has been a successful program and would love for you guys to participate. Amar, I don't know if you had a question.
Yeah, just a quick question. You mentioned how much shared savings Ortho Bethesda has had. I'm a family physician in a small practice. I'm just curious if you have any data on primary care practices and like how many episodes typically they're doing and what kind of shared savings they are seeing?
Yeah, I don't have the exact number, but I have seen primary care doctors groups, some of the larger groups like Privia actually see hundreds of thousands of dollars in savings. Um, they would qualify for the condition-based episodes that exist. And so because they're a primary care physician, because they're attributed to a significant amount of episodes, you will see that you will be qualified for a lot of these condition-based episode management, everything ranging from like sinusitis to osteoarthritis to low back pain. And you will be able to earn savings on that. And then also for yourself, Amar, um, you don't have to do MIPS reporting, which is expensive to do it through your EHR. And most practitioners, if they're not part of a huge health system, are seeing a penalty because, it's a zero-sum game where certain people are awarded a bonus while other groups are awarded a penalty. And if you're not on top of this, then it could be a problem. And so I've seen a lot of doctors groups in the state of Maryland who have actually seen a penalty for it. Okay, I'll be there in a second. All right, I'll be there in a second, Eva. Okay.
Great. Thanks a lot. I appreciate it.
Are there any other questions for Olivia or for Dr. Gruner? Okay, well, then thank you all for joining us. Thank you, Dr. Gruner. Thank you, Olivia, for taking the time to explain EQUIP. And hope you all have a good weekend and enjoy your summer. Thank you all.
Thank you. Have a good night.